is Alnoor Abdulla from the University of British Columbia in Canada. Welcome.
Thank you. I'm going to try and share my slides, and I hope you can hear me as well.
Yeah.
You are well heard. Thanks a lot.
Terrific, terrific. I want to thank the organizers for giving me this opportunity to speak to you today. It's, we started the session today, it was 4 a.m. for me, and now it's getting to be about 4:50 a.m. in the morning. So I'm going to try and do the best job I can at this time. Okay, the topic that I'm going to talk about is about lipid management. And I'm sure you've heard many presentations about lipid management, but I'm going to set the stage where I believe that we have had excellent run with the statins, and that maybe in the next 5 and more years, we will be using other lipid lowering agents, much more so than statins as the outcome studies become available. So I want to set the stage for what's going to happen in the next 2, 3, 4, 5 years in terms of our clinical practice. I have no conflicts to disclose for this presentation. I receive no funding from pharma or from any institution. Right, we know that from the Framingham study and from Mr. Fitt's study and many studies epidemiologically that higher the cholesterol level, higher the coronary heart disease mortality. So we've known that for over 50 years. When we look at cholesterol though, cholesterol is carried in the blood with many lipoproteins and attached to many apolipoproteins such as apolipoprotein B or A. So we usually talk about LDL cholesterol, which is the low density lipoprotein, which has ApoB as part of it. And it has a very high concentration of cholesterol in that particle. So it is really a surrogate marker for the most atherogenic lipid particle. However, all the other lipid particles, starting right from the chylomicron remnants all the way down to VLDL or IDL, all have ApoB in them as the apoprotein, and all have some degree of cholesterol in them. So all of these particles that are attached to ApoB are atherogenic. It's just that the LDL is the most atherogenic of the lipoprotein particles. And we have used this as a marker and as a surrogate to understand the total atherogenic risk. Whereas the cholesterol that is connected to ApoA particle, lipoprotein, are non-atherogenic, okay? So since that is the case, the total atherogenic risk can be determined by measuring the total cholesterol and then subtracting the HDL cholesterol from that. And the rest is what we call non-HDL cholesterol, and is actually a more accurate and a fuller understanding of the total atherogenic risk and the outcomes that the patient may suffer. And this has been shown in many studies. You can see for different levels of LDL cholesterol, the level of non-HDL cholesterol is actually a better predictor of the coronary risk, and not only a better predictor of the risk, but a better predictor of the outcomes related to various treatments. However, we have had studies done over the years, over 35 years, that have primarily measured LDL as the lipoprotein marker for the total atherogenic risk. And we have known that increased levels of LDL correlate with increased risk and outcomes of coronary heart disease. We have also learned with multiple studies that lowering the LDL cholesterol improves the cardiovascular risk and its outcomes. So LDL is causally related to the atherogenic process. And we have learned from multiple studies that approximately 1 millimole lowering of LDL cholesterol will lower your cardiovascular risk by about 20 to 23%. So remember this number, 1 millimole lowering of LDL gives you about a 20% decrease in cardiovascular risk of outcomes. And this does not matter what method you use to lower the cholesterol. The weaker agents will lower it less and get a less outcome benefit. Statins will lower it by about a millimole and give you about a 20% benefit. And some of the newer agents will lower it much more and give you a higher degree of outcome benefit. So LDL lowering by any method is the point of therapy in lipid management. Over the last 35 years, we have had multiple statin studies. Over 90,000 patients have been studied in randomized trials, and we have known from statin studies that statins are the most effective medications we have now of lowering the LDL cholesterol. And whether we are looking at secondary prevention patients or primary prevention patients, or really high-risk patients who have already vascular disease and diabetes, the statins will decrease the risk. And again, that formula holds. 1 millimole reduction of LDL cholesterol, doesn't matter what the baseline risk is, it will decrease the risk further by about 20%. So the statin studies have demonstrated to us that outcomes are significantly improved. And if you look at all major vascular outcomes with 1 millimole lowering of LDL, using statins, we get approximately a 20% decrease in outcomes of cardiovascular events. Total mortality is also decreased significantly. However, the patients still do die of other causes, and statins don't prevent motor vehicle accidents or cancer. So obviously patients are going to die of other things, but total mortality decreases, whereas coronary heart disease mortality decreases much more. So why do we need other LDL lowering agents when we already have statins and they have such high degree of efficacy? And that's the reason for that is statin has many limitations. And I've divided the statin limitations into 4 categories. Intolerance to statins, whether it's direct side effects of the drug or the perceived side effects of the drug in some patients related to the nocebo effect or fear. The second category is variability of statin effects. Statins have a very poor pharmacodynamic profile, and I'll show you that. And the other problem is adherence. You're going to have to take this medication every day, essentially for the rest of your life. And these patients are taking multiple other medications, and polypharmacy becomes an issue. The fourth problem with statins is nowadays trying to get the LDL levels really low to the more aggressive targets for the very high-risk patients. We cannot get sufficient lowering of LDL to reach those targets with maximally tolerated doses of statins. About 65% of high-risk patients do not reach their LDL goal with the use of statins presently. So just go through the statin limitations quickly. The adverse effects, yes, there are side effects that are directly related to the statins. But the problem with statins is the baggage it carries from the lay press, from the internet, from family and friends, anecdotal cases, doctors giving them information about side effects, pharmacists giving them a list of side effects to take with them when they prescribe the medication, nurse education factor. Patients begin to learn and know and anticipate the cardiovascular the adverse effects or the side effects of statins, and they get what is called the nocebo effect, which is essentially a result of the negative thinking or the fear related to a drug that it may give you side effects, and then you get those side effects. So the symptoms in patients who are taking statins are not all, therefore, related to the statin itself. And these are the statin-related side effects that we all know about. Myalgia is the commonest problem, but the other ones are extremely rare. Rhabdomyolysis essentially occurs in patients who are taking statins, plus another drug that potentiates that risk factor, such as certain antibiotics or immunosuppressive drugs or gemfibrozil or drugs like that. So the second statin limitation is the pharmacodynamics of statins. This is a study which shows that all the patients in this study received 10 milligrams of atorvastatin. And each line is a single patient. And you can see in men and women, the response to that same 10 milligram dose of atorvastatin was extremely variable. So this is related to the drug pharmacodynamics and patient effects. And the two are such that in some patients, you get a very significant lowering of LDL, whereas in some, you get hardly any. So that's a difficult drug to use when you cannot predict the exact degree of LDL lowering. The other problem with the pharmacodynamics of statins is that they have a flat dose response curve. And so you give the first dose and you get a remarkable decrease in LDL cholesterol. This is group effects. Within the group, there are some people who will get more or much less lowering of LDL, but this is the group effects. So the first dose gives you substantial lowering of LDL, but as you keep doubling the dose or tripling the dose or quadrupling the dose, you get less and less benefit of LDL lowering. And that occurs with almost any statin. And you get the initial benefit with the first dose, and then as you keep doubling or tripling the dose, you get less and less benefit. So they have a flat dose response curve. The third limitation is statin adherence. And we all know that this is a big problem in certain parts of the world. We still call it compliance, but we are politically correct in our part of the world. So we are afraid to use the word compliance, so we use adherence. And you can see here that statin benefit really primarily is associated with those patients who take their statins more than 80% of the time. And the decrease in all-cause mortality has primarily been shown in patients who take their statins essentially very regularly. This is looking at the persistence of statin. So you take the statin for 1 year, you take it for 3 years, you take it for 5 years, and you can see that the benefit, the odds ratio of having a bad cardiovascular event keeps dropping versus patients who are not taking statin. So if patients who are taking statins for 5 years have an 80% reduction in cardiovascular event rate. So the persistence of statin dosage is of great importance. The other side of the coin is patients who abruptly or without knowledge of the doctor stop their statins. And that happens very often. And what happens to them? They end up in the emergency room with destabilization of their illness or cardiovascular events. They can be very bad and they may need hospital admission, and there is mortality associated with it, which is statistically significant. So stopping the drug has its bad consequences. The fourth limitation is insufficient LDL lowering. And we know that you need to get the LDL levels particularly low, almost to the level of 1.8, 1.4, 1.0 to get benefit in the very high risk and the very, very high risk patients. And guidelines are evolving, showing more and more aggressive targets for lipid lowering. And unfortunately, statins are unable to do that. This is a study conducted all across the world, and the data is essentially similar, no matter which part of the world you are practicing it. And so we'll look at the overall data. And you can see that when somebody looks at a target of 4.15 of LDL, well, you can get 90% of the people there with the present lipid lowering therapy. But when you are looking at very high-risk patients and you want to get the LDL below 1.8, which is less than 70 milligrams, only 20 or 25% of these patients are reaching that target. So we have a large number of patients with maximally tolerated doses of statins who are unable to reach their target and therefore don't get the full benefit of cardiovascular event lowering. So when you look at cholesterol, there is primarily production of cholesterol in the body from the liver, which is really the main component of the blood cholesterol. It comes from internal production, but some degree of cholesterol comes from the diet. But the dietary cholesterol itself, I'm not talking about the fats or the trans fats, I'm talking about dietary cholesterol itself, contributes very little to the level of blood cholesterol. And to lower the cholesterol, you have to either decrease its production so that you upregulate the LDL receptors, or you increase the clearance. And statins decrease LDL synthesis, cholesterol synthesis, upregulate the LDL receptor, which then draws in the LDL cholesterol from the blood and allows the clearance. So, and we have discussed these statin limitations. So if we are looking at any of the newer drugs for LDL lowering, they have to improve the present limitations of statins. And we've been using ezetimibe for quite a while. It's a 10 milligram dose in everybody. It's a single strength. So it is a very easy drug. It has a single dose, works in everyone essentially the same way, and a fairly predictable pharmacodynamic effect. And how do ezetimibe, how does it work? We know that the statins work by decreasing the synthesis, primarily in the liver, but in other organs as well. When you have dietary cholesterol or cholesterol esters coming in with the bile or bile acids into the duodenum and the upper jejunum, there is an enterohepatic circulation, and that cholesterol and cholesterol esters as form of chylomicron remnants are reabsorbed back and reach the liver through the lymphatics, and then you develop increased blood cholesterol levels. What ezetimibe does is, by blocking the Niemann-Pick receptor at the jejunum level, blocks the absorption of these cholesterol esters and cholesterol found in bile acids. So it's a dual mechanism. You decrease the synthesis with statin, you decrease the absorption with the ezetimibe, and therefore you get synergistic effects. This is not a very good clear slide, but you will see that when you use statins alone, you have to double the dose, triple the dose, quadruple the dose, and you still get a very little benefit to reach your 50% reduction of LDL cholesterol that's often required. Whereas if you use a small dose of statin and add ezetimibe to it, you are often able to reach higher concentrations of LDL lowering, and therefore you have a synergistic effect. So this allows you to use lower doses of statins in patients who seem to have some side effects related to the drug. On the other hand, it also allows more of your patients to reach the high aggressive target levels that are necessary in the very high risk patients. And you can see essentially for the high targets where we need to get the LDL cholesterol very low, the addition of ezetimibe to statin essentially doubles the number of patients in terms of percentage that will reach the required target levels in order to decrease the outcomes, bad outcomes. The IMPROVE-IT study clearly showed that cardiovascular death, non-fatal MI, or stroke was significantly reduced with the use of ezetimibe added to statins, and there is approximately a 10% further improvement in the relative risk of major cardiovascular events when ezetimibe is added to a statin. So ezetimibe provides this dual blockage with statins, and therefore the adverse effects are decreased because you often can use lower doses of statins. The dose response is fairly consistent, and the same dose works for every patient. There is a better adherence, I think, because of patients who may have myalgia or so, and they're not reaching target, and you want to raise the cholesterol, the statin dosage, they are not going to really like to take that. So you keep the statin dose the same or lower it and add ezetimibe, and they're more likely to adhere to the therapy. And you have further lowering of LDL and improved outcomes in addition to the use of statins. So we are in a situation where there is improvement over statins when we use this drug in combination. Bempidoic acid is going to be available fairly soon. It comes in a 180 milligram tablet. It comes as a tablet combined with ezetimibe. What is bempidoic acid? Well, I'll explain to you. We know that cholesterol production in the liver and in other organs goes through an enzymatic process, and HMG coenzyme A reductase is a rate-limiting step, and statins inhibit this and therefore decrease the synthesis of cholesterol. Bempidoic acid is a prodrug, and it enters the liver where it is conjugated into an active drug. And blocks the synthesis of cholesterol at a much higher level upstream in the cholesterol synthesis pathway by blocking a different enzyme. So why is that important? It's important because bempedoic acid is a prodrug. In order for it to work, it has to turn into an active drug. This conjugation can only occur in the liver. So bempedoic acid becomes a liver-specific action drug that decreases the synthesis of cholesterol. It has no effect at the muscle level or other organs because the other organs cannot and muscles cannot conjugate bempedoic acid to its active form, and therefore there is no metabolic activity of bempedoic acid in the muscles or in other organs, whereas statins do work in muscles and other organs. And therefore we believe that the myopathy and the muscle side effects of statin lowering may be improved with the use of bempedoic acid. In people who continue to have high cholesterol levels despite maximally tolerated statin, bempedoic acid lowers it further. In people who cannot take statins at all, bempedoic acid brings down the LDL cholesterol to just about the same amount as statins do. So it is a statin that has the potential of giving you no muscle side effects. And the earlier studies seem to confirm that. When it is combined with ezetimibe, you get the same kind of pattern as with statins, and you get a synergistic effect and a significantly increased lowering of LDL cholesterol, with lowering of non-HDL cholesterol as a group, and lowering of ApoB when it is used in combination with ezetimibe. The outcome study is underway. We will have the results fairly soon, by the end of this year and certainly next year, to see that it does decrease the coronary heart disease outcomes just as well as statins. And we are going to look for 1 millimole lowering of LDL cholesterol by bempedoic acid if it decreases the coronary event rates by 20%. All right, so bempedoic acid, there's at the present seems to have no significant concerns with side effects over and above placebo. Particularly the myopathy seems to not occur. Therefore, there is an improved pharmacodynamics and dose response curve. One dose works and you don't have to be adjusting the dose. Adherence may be better if you don't get the myalgia side effects, and it will not carry the baggage that statins carry of the negative connotation in the media and the internet and family and friends. That whole nocebo effect problem that the statins carry will not therefore be carried on bempedoic acid. And we may be able to tell our patients we are not using a statin, we're using a non-statin drug. And we are waiting for the outcome trial to see if it actually significantly decreases the events. So going on to the Pcsk9 inhibitors, these are monoclonal antibodies, and they are given by subcutaneous injection. You cannot give them orally because they get degraded by the acid in the stomach, so they have to be given subcutaneously. They can be given once every 2 weeks or once every 4 weeks. The dose is essentially the same for every 2 weeks, and the dose is essentially the same if you want to give it for every 4 weeks, a higher dose. So what do these antibodies do? They neutralize Pcsk9. Now I want you to think of Pcsk9 and LDL. You have high levels of Pcsk9, you're going to have high levels of LDL. If you have low levels of Pcsk9, you're going to have low levels of LDL. All right, what does Pcsk9 do? The LDL receptors attach to the cholesterol in the circulating blood and internalize the cholesterol into the liver cell, where the endosome works on the receptor and the cholesterol particle and degrades it. So the cholesterol is then excreted in the bile, and the LDL receptor is supposed to recirculate and go back up to the LDL, to the liver surface to work on more LDL clearance. The problem with Pcsk9 is it also binds to the LDL receptor. So when the LDL receptor has Pcsk9 bound to it, it will go into the endosome and therefore end up at the lysosome and will degrade the whole particle, releasing the cholesterol, but also destroying the LDL receptor. And therefore, this recirculation of the LDL receptor back to the surface is blocked. And so you have less LDL receptors in the presence of PCSK9 and downregulation of the PCL receptors. You give a monoclonal antibody, it goes ahead and binds the PCSK9, and therefore the PCSK9 cannot bind to the LDL receptor, and therefore you do not get the degradation of the LDL receptor at the endozyme, at the lysozyme level, and therefore you increase your LDL receptors on the surface and increase the clearance of LDL from the plasma. Here is the therapeutic dose of 140 milligrams of PCSK9 evolocumab, and you can see with the 140 milligram dosage given every 2 weeks, you drop the LDL cholesterol dramatically, and you keep it absolutely under control with every 2 week subcutaneous injection, which is extremely easy to take. It's like a ballpoint. You just kind of put it anywhere on your body where you like, and then you hit the knob, and the 28 gauge needle goes in just so much. The drug is released into the subcutaneous tissue, and the ballpoint pen-like injection clicks, and you know it's in, and you just remove it, and it's done. And then you're fine for the next 2 weeks. It also lowers ApoB and lowers Lp(a), which statins do not do. Outcome studies clearly show with alirocumab that you decrease the event rate even further, in addition to maximally tolerated statins, and you do that with evolocumab as well. You improve the outcomes, and the longer you stay on this drug, the further improvement or benefit you get with evolocumab, which is a PCSK9 inhibitor, by using a monoclonal antibody. So the adverse effects are very few. Essentially, the injection site minor reactions, but there is no significant additional adverse effects noted over and above placebo or patients who are already taking statins. You get a highly consistent and durable effect. So the pharmacodynamics are excellent. You get improved adherence. You just take the injection once every 2 weeks or once every 4 weeks, and you are done. And so your adherence level is much better. It's highly effective in lowering LDL cholesterol and has been clearly shown to improve outcomes over and above statins, or in patients who cannot tolerate statins at all. Well, I'm going to talk to you about a drug that is going to be an absolute game changer. You are going to use this drug over the next 3 to 5 years. And this is going to be the main game changer in lipid management. It's called siRNA, small interfering RNA. It's not a messenger RNA. And this is, again, RNA protein, and therefore is degraded in the stomach. So you have to give it subcutaneously. There is essentially one dose. You give it on day 1. You give it a booster on the 3rd month. And then you just have to give it twice a year. That's it. That little subcutaneous injection twice a year. When the patients come for your flu shot or regular checkup, you can just administer it, or they can administer it at home, and their cholesterol is controlled completely for that whole 6-month period and then onwards. Well, how does this work? I told you about PCSK9. It's a problem. It ends up degrading the LDL receptor, and therefore you have less LDL receptors on the surface, and you cannot clear the LDL from the blood. PCSK9 is produced in the liver from the ribosomes after the messenger RNA comes from the PCSK9 gene. When you have inclisiran on board, what it does is this RNA strand, siRNA, small interfering RNA. So it's going to run interference. It gets into the liver cell, and I'll show you how it specifically only gets into the liver cell, where the messenger RNA is produced from the nucleus to go to the ribosome to produce PCSK9. What this RNA strand does is completely interferes. It runs an interference with the messenger RNA and scrambles the message. Scrambles the message so the ribosomes cannot produce PCSK9. So the monoclonal antibodies are inhibitors of PCSK9 that we just talked about. And inclisiran is decreasing the production of PCSK9, and therefore the LDL receptors are not degraded in the liver cell. Cholesterol is released and excreted, and the LDL receptors go back to the surface to keep clearing the LDL from the plasma. What's so important about this mechanism? This siRNA is attached to a conjugate protein, which is extremely specific. What this conjugate protein does is that it can only be absorbed into a cell that has this SBER receptor. And these SBER receptors are only found on the liver surface. So this siRNA can only enter hepatocytes. So it becomes a particularly liver-specific drug. Secondly, when it releases the SBER receptor, it goes back to the surface to take in any more siRNA that is necessary. In the meantime, the RNA strand inside the liver cell is continuing to scramble the message of the messenger RNA, and no more PCSK9 is produced. But the RNA strand that you've injected attaches to a RISC protein, RISC complex, RISC, and it sits there, and any messenger RNA comes out to produce PCSK9, it keeps scrambling the message. And therefore it lasts for 6 months and does the job. So it becomes hepatospecific and long-acting. You can see the effect of LDL lowering is absolutely dramatic. You give the injection on day 1, give a booster on the 3rd month, and from there on, you just inject every 6 months, and you have a dramatic lowering of the LDL cholesterol. In terms of the side effect profile, is essentially the same as placebo, showing no significant additional side effects noted up to this point. The only increased side effects are at the injection site, giving you mild or moderate injection site reactions, but none of the patients got severe or persistent injection site side effects. So it has minor side effects as we know now. We don't know the long-term effects. It is extremely potent, consistent, and durable response in lowering your LDL cholesterol. It has the potential for superb adherence when you only have to give this twice a year. And it is extremely highly effective in patients who cannot reach target with maximally tolerated doses of statins, or even in patients who cannot tolerate statins at all. We are awaiting the Orion 4 trial results, which should come out later this year, hopefully, and we are looking at the outcome results to see if this drug actually decreases coronary events, which is really what's most important to our patients. Lastly, I will talk to you about once and done therapy for lipid lowering, and that's CRISPR gene editing. And what this does, it edits the gene in the liver cell, which is responsible for producing PCSK9. So there are people who are born with a loss of function of this PCSK9 gene. And these people who have loss of function of PCSK9 gene have lower levels of PCSK9 and therefore have lower levels of LDL cholesterol all their life. And because of that, they get an over 80% reduction in coronary event rates throughout their life because they don't have PCSK9, and therefore their LDL cholesterol levels drop significantly. So this is what we have learned from nature. We have also learned from nature that there are some people who absolutely have the absence or a mutation that is completely not allowing them to produce any PCSK9. They grow up healthy, they are intelligent, there is no brain effects, they are physically strong, and they have extremely low LDL levels to the level of 0.4 or 0.38 in this case. And they seem to do well with very low LDL levels and no coronary event rates. So we said, fine, if nature is doing this, and these people are not getting coronary events, let's go in and let's mess up the gene now. we were messing up the messenger RNA, we were messing up the PCSK9 as an inhibitor. Let's go right into the nucleus and alter the gene that produces PCSK9. And the first study was published in Nature in earlier this year. And this is the first case of gene manipulation by CRISPR technique in a non-human primate, which demonstrated that in the second part of the study, where they learned how to do this a little better, you can see that PCSK9 levels dropped dramatically, and it was a once and done therapy. That's it. You do it once, and it's done forever, and it lowers the PCSK9 levels in the blood dramatically, and therefore your LDL cholesterol levels are lower. And we are going to move into the next phase of using it in humans. It is already used, this technique, in humans with other diseases such as beta thalassemia and sickle cell disease and some of the lymphomas now and the leukemias. They are doing gene editing by this CRISPR technique. I have to put in a plug. This CRISPR technique was developed and invented in Canada. So to summarize, you know that statins work in the synthesis of cholesterol. The problem with statins are those limitations. I'm going to end in the next slide. Bempidoic acid may have advantages in this regard because it may not give you liver side effects. The PCSK9 inhibitors, monoclonal antibodies, are a big advance, and inclisiran will be a major advance because it decreases the production of PCSK9, and then we may be going to gene editing with CRISPR technique. So we are moving from the statins, statin ezetimibe combination, to maybe bempidoic acid ezetimibe combination. We are using PCSK9 inhibitors, but we will have the game changer, inclisiran, which is decreasing the production of PCSK9. Thank you very much, and I apologize for having gone over time by a minute. Thank you very much for the opportunity.
I must say, I am so excited because imagine having an injection, subcut injection, one time in 6 months. That is much better because people do not take their medication because they talk about cramps. They, a lot of younger men about erectile dysfunction and all those things, they're complaining about that and I don't want to take the medication. Imagine if you must even increase the dose and it's still a bad thing. So thank you for giving us some hope.
I like to thank you for the very beautiful lecture, up to date and having new knowledge. One of the best lectures about lipid therapy I heard in a year. Thank you. No questions.